में प्रॉब्लम आ रहा है उनको।
अच्छा, मैं कॉल करता हूँ अभी उनको।
Who will be presenting the first case?
Sir, it is me. I will be presenting.
Prateek, sir.
Oh, okay.
Sir, I had a message text with Prashant. He is not able to join.
Mm-hmm.
He has got some emergency and he is in the train right now.
Okay.
Jayant sir, good evening.
Good evening. Good evening.
Sir, good evening.
गुड इवनिंग सर।
Good evening.
Sir, good evening.
Good evening, sir.
Good evening. Sorry for being late. And
So
गुड
we can
इवनिंग कैन सर।
Akanksha, should I
Good-
do
Yes,
I
sir.
have to change the host?
No, sir. Let it be, sir. So we can start now, sir.
Okay, okay, no problem.
Okay, sir.
So, shall I go ahead and start?
Am I audible, sir?
Yes.
Yes, Manish, you are audible.
Okay, okay, thank you.
Mm. Jan sir, please start proceeding. Sir, you are muted.
I said you take over. I'm late.
Okay, sir. Good evening, everyone. I welcome all of you on today's monthly webinar case-based series. And today, Central Zone is participating in proximal tibial fracture case-based discussion. I hand over proceedings to Dr. Shamshul. He will take over from here. Dr. Shamshul, please start. And Dr. Prateek, please share your screen.
So, thank you very much. Now, I will be sharing my screen, and I hope
Please unmute yourself.
are the slides visible, sir?
Yes.
Okay.
Yes, sir.
So, if everyone is happy, then I can start the this first case.
Yes, please.
Shall I? Yes, please. Okay. Thank you very much.
Yes.
So, I will welcome everyone for this monthly webinar conducted by ASAMI India. And the theme for this month is usage of ILIZAROV in proximal tibia fractures. So, setting share now it has stopped. Yes, so it is jumping forward. So I'm retrying to share. I think there is some issue again. It was fine a few minutes back.
So your screen is visible actually.
So now it is fine. So proximal tibia fractures are one of the subgroup of fractures which are special a bit. Why? Because, well, there is a spectrum, and the spectrum is because of the fracture morphology and whether they are involving the joint, whether they are purely metaphyseal or metadiaphyseal. At times, even what is important is that they might be simple, many times comminuted, open and closed fractures like any other fracture of the body. Importantly, what is important is that in proximal tibia fractures, there is a soft tissue envelope which is often compromised. And this might be there even in those fractures which are closed. And these fractures might have significant swellings and even blisters. Many times you see vascular injuries associated with these fractures, and all these actually affect the decision-making process. So the standard reference for making diagnosis and for opting for trauma, which we all orthopedic surgeons tend to refer, is that from AO. And if we look at the AO trauma reference, then depending on the fracture type and fracture pattern, the management can be non-operative. It can be an bridging X-fix, which might be a temporary one. It can be an AO type modular X-fix. or you can have a non-bridging external fixator which can be used in definitive mode. Then plates, which might provide angular stability or which might not. And all these are those when you have fractures which are displaced, but you have a good soft tissue envelope. Then you have the minimally invasive fixation. And for the end, if you see, then AO is also now brought up the usage of ring external fixator as a definitive mode. And there are indications, especially severe open fractures with bone loss and those fractures in which the soft tissue cover is poor. Importantly, they say that these can be should be avoided if stable internal fixation is possible, where people might disagree with this. But if we consider all these indications, let us start the first case for today. So this is case number 1. Age is a 25-year-old male who was riding a bike under influence of alcohol and he collided with a tree. So this was somewhere in between village and the highway connecting that village, and he was brought by his friends who were on another bike. So he was, at the time of presentation, he had loss of consciousness. NCCT was obtained, which was unremarkable. EFAST showed mild pleural effusion. And then he had multiple orthopedic injuries. Importantly, all of these were on the right side. He had an open grade 3A fracture of the distal femur, comminuted fracture of the patella, again open, comminuted fracture of the proximal tibia on the right side. And this comminuted fracture of the proximal tibia had communication with the femur fracture wound also. Then there were multiple comminuted open grade 3A injuries of the hand. So these are the radiographs, which we can appreciate that this is a type of floating knee. The tibia has got a fracture, which is intra-articular with a metaphyseal extension, and the proximal diaphysis has got multiple comminution. Fibula is also fractured. The femur is completely shattered, and all the patella is also fractured. If you see the hand also, he has got injuries. Now, with this picture in place, so do we require other investigations at any CT or any other investigation at the present moment? So, well, we didn't proceed with other investigations for the bony injuries per se. And after stabilization of the patient, his life was managed first, and then we addressed the injured limbs. Took up the patient for surgery, and the surgery plan was a thorough debridement and a reconstruction. So during debridement, there were many loose fragments, especially in the region of the femur, which had got no soft tissue attachment, and there was contamination. So they all were actually removed. And we reconstructed. If you can see that the reconstruction, it appears as if everything has been fixed well, but all these fixations are primarily with the help of KYs. So there was also a fracture, as we had earlier seen in the pre-op X-ray, in the proximal tibial area, which was intra-articular, and there was a metaphyseal extension. So now at this moment, we thought of using the ILIZAROV ring fixator as a definitive mode. And then we applied the frame on the tibia as well as on the femoral side. For tibia, we put in a screw to address that split in the metaphysis, which was extending into the joint. And then we used the ILIZAROV frame and spanned the comminuted area without trying to open up that part. On the femoral side, we used multiple screws to hold the reduction, which we had earlier achieved and had stabilized with screws, with KYs. And after that, we applied the frame. We can see there is some fracture gap is there. And this was because we removed and discarded those fragments which were quite loose. The hand also was again taken care of by a debridement and then KY fixation for the fractures. So at 3 months post-surgery, we can see that on the tibial side, some amount of bridging callus here and there has started to appear. The alignment looks reasonably well. And at this stage, what was seen was that on the femoral side, there was still a gap. So instead of changing the frame altogether, we took the patient up, docked that area, and harvested iliac crest bone graft and filled that up. We allowed the patient to ambulate. So this was at 6 months of surgery. The patient is still with the frame on, but at this time, he was walking well. Then at 8 months of surgery, at the 6-month period, at this time, we dynamized and removed the tibial frame altogether. The femoral frame was retained because though the femoral side had started to heal, it was not completely glued up and it had not completely healed. So now, as we can see that the screw which we had put is still there in the tibia. Rest of the tibia, they have the fragments you can appreciate, but it has all healed up by indirect healing. And on the femoral side, again, callus has started to, that can be seen now. So this was at 10 months after surgery. The tibial side is all healed up. Femoral side has started to heal. And we can see that on AP, the alignment looks fine, but on the lateral view, there is some amount of translation on tibia. At this stage, the patient, we dynamize the patient, and then we remove the femoral frame also at 13 months of age. So at 13 months post-surgery, he was pain-free. Ambulation was without any support. But the primary issues which was there was a limb-length discrepancy of 3 centimeter, and he had limited knee flexion of 30 degrees. So with this case, so these are the points which I thought can be discussed by the expert panel, that whether the modality was acceptable, whether we were right in proceeding with usage of an ILIZAROV frame and not proceeding with an internal fixation with a plate. And if that was the choice, what could have been the outcome, and whether the execution was fine, whether we were using adequate number of rings, pins, wires, and what about the rehabilitation of cases like these, in those cases where you have a floating injury. So with this, I would like the opinion of the experts on the case, please.
Let's start with your opinion in retrospect now. What if you got a similar case today?
So,
what would you do differently?
In retrospect, I think that probably I would have gone ahead and plated the femur and managed the tibia with the way I did, because
Correct.
the tibia actually healed well in reasonable amount of time, but the femur took a long time. And that might be a reason that the outcome, especially in the form of movement, which was now just 50 degrees, it could have been better.
Correct. So you had the femoral frame and the tibial frame on that leg for how long together?
All together around 1 year.
No,
So
both of them.
no, sir, the tibial frame was there for 4.5 months.
You're right.
But the femoral frame was there for 13 months.
Longer, right.
Yes, correct.
So with an intra-articular injury, if you have blocked the movement, the likelihood of stiffness increases.
Yes.
That's number one. Number two, in the femur, unless you have got gross soft tissue loss, which is not terribly common, after a debridement, etc., getting a fixation and soft tissue coverage on it is, pretty straightforward. It helps with your movement also.
Yes. So that we realized also, because initially there was bone loss, and with that bone loss, if we accept that shortening and use the plate, then coverage was even easier, because now we have shortened the bone.
Correct. So we have to resist this urge.
Yes.
To keep it out to length. One lesson we have to learn, especially as surgeons who can do the ILIZAROV, is shortening is a great way to reduce your healing time.
Yes.
And lengthening can always be done. In these complex injuries, getting it to heal becomes the first problem.
Yes. Correct.
So, and as you get better at it, maybe you can do the lengthening earlier. But a patient who's well healed at maybe 5 months and walking with a raise for 4 months, 5 months, and then you do a lengthening on him, should not be a very difficult problem, right? So people say, "Oh, patient is not affording." Or patient is that I think that is BS. Basically, patient is not if patient is not affording you, we really want to do something genuine for the patient, we cut our fees. When especially in the private sector, if you have to deal with a patient like this for 10 months, it's a drain on your resources. Constantly, changing something or explaining something or stuff like that. And ultimately, it is your results which count. So if you have a patient who's moving, and once it is discussed well, you'll hardly find a patient who refuses. Meaning, if I tell them that, okay, this way I will get you up and about in 5 months, I think generally they accept it. Any other opinions against what I'm saying? Jayant,
Yes.
Amar?
No, sir. I agree with your opinion. Just another thought process is if soft tissue conditions are good and if we are not opting for transport, so we can opt for early conversion to internal fixation, say at the period of 6 weeks, 8 weeks, like that. So that would also help a lot in gaining knee motion. Early conversion to internal fixation.
Correct.
Mm,
In this scenario, a thing was a bit difficult because that patient was from a village and he didn't turn up in proper time many a time. So if I'm showing the X-ray, last X-ray is not available because after I removed the frame, I sent him for an X-ray and he has not yet come. So I
Yes.
don't know where he has gone. So he might come up later.
You should give him the proper address of the X-ray center. No, he may have gone to
No,
some.
sir, actually, I'm in an
X-ray
hospital
center in
only.
his
I
village.
sent it to the institute's X-ray person only.
I'm pulling
And
your
then
leg.
and then that person goes away after getting X-rays or without X-rays. I got no idea. He might turn up somewhere later after some different issues.
Yeah.
So if
you have not
there are
shown the hand functions, what about the hand functions?
so hand functions are limited functions, but
The
actually,
one of the KOI
yes,
is
sir.
blocking the MP joint
So,
and never pass the wire to block the MP joint. MP joint is the one of the joint. Once becomes stiffened, then it's very, very difficult to recover. So
is
the
a point.
fixation technique for these metacarpals is very, very important. Passing nearby through the neck, or
Yes,
that is to prevent the MP joint as far as possible.
correct,
Never fix the MP joint.
correct. So I have one more interesting case to discuss.
Just one question, may I? Sir,
Yes,
Jayant,
please.
sir, yes, sir. Jayant, sir.
I said we'll first finish off with one case round and then the next case, if remaining, we'll add it after that. So
Okay,
that all the speakers get equal time.
Okay, as usual. Not
Just
an issue.
one question, Dr. Prateek.
Yes, please.
Yeah, in the distal femoral fracture, I would just suggest one more ring because it is just one ring proximal to the fracture. So I would advise one ring or one arch.
Actually, sir, there was one ring, one arch,
Okay.
proximally.
Okay.
One full ring and one Italian arch.
Okay, then it's fine. Yeah.
Yes, and distally in the fractured fragment, we had only one ring plus drops because we connected it with the tibial ring also. So we thought that instead of loading that area up, one might be helping the other in supporting.
Right, right. Because stability is very important in early healing, right?
Yes, correct, sir.
So Shamshul, who's the next?
So I will stop sharing my slides now.
So Ritesh is coming up with his case?
I think Ritesh is coming.
Yes, sir.
So we have AIMS Brigade now. Followed by government medical colleges.
Thank you, sir. So I will be sharing my screen now.
John, sir, is unable to join because of some issues, computer issues.
Okay.
So is it visible?
Yes.
Please go full screen.
Yeah. So actually, I also had prepared two cases, but I will present one case only as of now. And if time permits, then we can discuss the second case. So this was a 2-year-old girl, and she sustained injury around 12 months back. And at that time, she had sustained open fracture of left proximal tibia, which was managed somewhere else. And to us, she presented with a varus knee deformity on the left side and a limb length discrepancy of around 3 centimeters, as we can see in these images. And so this is not a case of fresh injury. It's basically a complication or sequela of previous injury. And these were her images at the presentation. We can see a gap in the proximal tibia, a gap non-union, a hypertrophied fibula, and subluxation of the proximal tibiofibular joint. And in this video, we can see there is frank, painless movement at the non-union site. And we tried to see the movements between the proximal fragment and the distal femur, so that was also relatively preserved. So what can be done for this child? So we had different options. We can debride the non-union site and put cancellous graft, or after debridement, one can opt for a fibular strut graft, or we can shorten the fibula and do acute docking and stabilize it, or try a bone transport with ILIZAROV. And I'm sure there will be other thoughts also, which can be discussed at the end of this presentation. So what we did was, according to this paper, we all know non-vascularized fibular autograft is a viable option, especially in children, for the treatment of gap non-unions. And this paper was published in 2020. The average age of children, the average age of children were 9.5 years. And the authors achieved union in almost 80% of the cases at an average time of 28 weeks. Although 4 cases sustained refracture, but ultimately all united at the final follow-up. And this is another study with similar results. Here also the authors reported the incidence of union in around 90% of the cases, with good functional recovery in around 80%. So this is what was done for this child. We used the fibular strut graft from the ipsilateral fibula, debrided the non-union site, put that graft in the gap in the proximal tibia, and stabilized it with an intramedullary K-wire through the heel. And ILIZAROV frame was mounted for additional stability. And simultaneously, we did a corticotomy in the distal tibia to correct the limb length discrepancy. So these were the images immediately after the surgery. And we can see at the end of 8 weeks, the distraction has gone satisfactory. The limb length looks equal on both sides. And the non-union site, which was grafted by the fibula, that is also showing satisfactory healing. So at this point, the further distraction was stopped. And this is at 8 months. We can see the union look is looking satisfactory, and the regenerate is also consolidating well. So here the foot frame was removed and patient was made to bear weight. But this is at 10 months. Now here the original non-union site is looking okay, but there is a deformity at the distal end of the regenerate, maybe because a single ring was not sufficient enough to provide stability here. But we kept on observing. We didn't do anything at this time. And this was at 12 months. The distal end of the regenerate and distal tibia junction, it's looking okay now. So here the proximal ring from the leg was removed, as the fibula has incorporated well in the non-union site. And the patient continued walking. She was more comfortable now. And these are successive images. So we can see the healing is looking satisfactory. And at the last follow-up at about 24 months, there is good remodeling also, and it is getting better day by day. And as it is in the plane of the movement of the knee joint and ankle, so we are expecting that it will remodel well. These are the clinical images at final follow-up. We can see the deformity is well corrected, limb length discrepancy has been corrected, and she has good range of movements at the knee joint, and overall the functional outcome is quite satisfactory. Sorry. So this was the end of the first case. So,
Just show her X-rays, Ritesh, again, the last X-rays.
okay, sir.
So
So,
now, I mean, good result. Again, to ask you the same question as what we asked Prateek. How will you treat the same patient again, or what advice will you have for someone who gets this kind of a patient?
So, sir, I think shortening the fibula and doing acute docking because the gap here was not very big. So I think up to a gap of 4 centimeters, we can easily go for acute docking with some cancellous graft, stabilize it, let it heal, and we can plan the lengthening in the second stage. Anyways, there has to be limb-length discrepancy later on also because the other limb is growing normally. So for a beginner, I think instead of doing everything simultaneously, we can plan it in stages.
Just go back to where before you treated her.
1 minute, sir.
Yeah.
This was, yeah.
Correct. Okay. So you showed one international paper. You should not forget that I think Sandeep Patwardhan has probably the largest series. He's got a series of, if I'm not mistaken, around 32 cases where he has used a avascular fibula.
Yes, sir. Yes, sir.
With
Right.
good results. So that is one of the important takeaways, that in children, you don't necessarily need a ILIZAROV.
Yes.
You can put in a fibula, and if you put in a fibula because the skin is good. So if you put in a fibula with an intramedullary wire, the chances of this healing are extremely good because periosteum, etc., is maintained. This was a sequestrum which came out, right?
Yes, sir.
So the periosteum is maintained, and if you put in a fibular strut there with a wire, effectively you're tensioning the periosteum, giving it stability maybe by a plaster cast, you can get equally good results. So we have to remember that essentially we are reconstructive surgeons and not necessarily always ILIZAROV surgeons. You could also use, maybe someone will say you can use a JESS. Yes, you can. The other thing I want to point out is that is not only this patient going to require a lengthening in the future. If you go back to your last X-ray.
Yes, sir.
The final result. So this has healed well, but this thing, proximal tibial physis, is liable to be damaged.
Yes, sir.
It may not grow well. So I would keep a close watch on this patient to see that the head of the fibula is not started going up. Two things happen with that. One is you get varus.
Yes, sir.
And secondly, you can get an induced rotational deformity because the distal end of the fibula is on the lateral aspect of the tibia, and the proximal end of the fibula is on the posterolateral aspect. So if the fibula grows quicker and longer, it twists. These patients get an internal rotation deformity of the tibia. So I would keep a close watch on this to ensure that nothing is going wrong there. And if at all one of the fibular epiphysis is growing faster, then I would consider ablation of that epiphysis before a deformity develops, or when there is a minimum slight deformity.
Right, sir.
Of course, as you pointed out, it will require a lengthening later on.
Even you can use the untenting procedure also. It's a well described procedure. we can
Yes.
use that procedure also.
Sir, in the second case, actually, I was going to show the same thing. So maybe if time
You
permits.
can
एक
just
राउंड
one.
एक राउंड हो जाएगा तब आएंगे वापस.
Yes, sir.
Yeah,
I
it
agree
is
with you,
a
sir, that
question, sir.
yeah.
How did you prevent the proximal tibiofibular joint migration of fibula?
Sir, so once we removed the fibula, gradually it came to its place, and with the length, like it came to fall. I can show you here. Like I did nothing for that because I had taken a graft of around 4 centimeters. So pulling the fibula down was not an option, but as we can see here, it has fallen back automatically in the process of lengthening.
Okay.
So right here, this is just after the first surgery, like just after the
I
procedure.
just wanted to know whether the wire was going through the fibula or not.
No, sir, because there is a gap in the fibula. That part of the fibula is used. So there is no connection between the proximal fibula and distal fibula. If it is one segment, then we can pull it down by transfixing the distal tibiofibular joint. So here I did nothing for that. It automatically came back to its place. And I agree with like Mangal sir that in children, usually ILIZAROV frame is not needed, but here we were planning lengthening also simultaneously. So I mounted it.
Okay.
Good case. Next.
Thank you, sir.
Next case, Shamshul, who's presenting?
Next,
Dr.
we have Dr.
Manish.
Prashant.
Prashant has probably
Yeah.
not joined.
Okay. Then we have Dr. Manish.
Yes.
So I will stop sharing.
Yeah, please stop share.
Good evening, sir. Am I audible?
Yes.
Yeah, your screen is not seen.
Yes, sir.
Sir, are you facing any issues?
Yes. Just I am
Sir,
saying.
at the bottom, there will be one green color icon with an arrow pointed upwards at the bottom
No.
of your screen.
Let me share once again. My presentation. Okay. Is it visible?
Yes, visible.
Good evening, sir. First of all, I would like to pay thanks to ASAMI India and esteemed faculty. I have a limited experience of proximal tibia fracture fixation with ILIZAROV frame, but I will present a case. As Prateek sir already said, as an orthopedic surgeon, we come across with the variety of proximal tibia cases depending upon fracture configuration, whether it is extra-articular, intra-articular. Not forwarding. We can encounter with fracture dislocation also, and depending upon the soft tissue condition, we can come across with the open fracture as well as bad soft tissue. The treatment depend upon the fracture configuration and the soft tissue status basically. Most of the orthopedic surgeon do the stage procedure in these type of the fracture in which there is the intra-articular extension and the soft tissue is not good. First, they apply the fixator, then let the swelling subside and wait for the definitive fixation with the plate. Different modality of fixation are being done with the orthopedic surgeon. These are the plate. Some orthopedic surgeon prefer nail intra-articular fracture also, but the principle remains same. What are they? The principle is fracture reduction. Sometimes it required anatomical and sometimes functional. And the second principle is fixation, that can be absolute or relative. Third, we have to follow the biology, both for the bone and the soft tissue, and early and safe mobilization to enhance the healing and avoid complications. Now, I'm like to present a case of 55-year-old male. There is the history of RTA come with the proximal tibia fracture. This is comminuted intra-articular Schatzker type fracture, Schatzker type 6 fracture, in which there is a lateral condyle, this is the middle fragment, and this is the medial condyle. Now, anyone like to comment or on the X-ray, what should be done in this stage? Okay, I would like to move forward. Second thing is there is the ACL avulsion also. This is the soft tissue status of the patient. Principally, the intra-articular fracture require the anatomical reduction and absolute fixation, while the metaphyseal fracture or diphyseal fracture require the functional reduction and relative stability. For that, we applied the ILIZAROV frame. First, we reduced the intra-articular fracture by the tenaculum, and fixation was achieved with the weeded wire from both the sides. After that, we fixed the distal metaphyseal fragment with the beaded wire to stabilize and to fix it with a drop wire. This is the X-ray after three months. The fracture has united. After 3 months, I have removed the frame. Unfortunately, I don't have X-ray after frame removal. This was the function of the knee of the patient, and he was completely doing his all activity, and range of motion are perfectly normal, and he is not having any instability of the knee also. So this is my one case. Thank you very much. I have only one case, sir. Sir, any input from the audience?
Number one would be not having a post-op X-ray. There is no real excuse. You should have
this is the post-op X-ray.
Post-op, I mean the post-removal.
Post
Post-removal.
नहीं सर, वो नहीं है सर, एक्चुअली सर
Exactly. So
वो मिस हो गया सर.
अगर मैं ऑडियंस में बैठ के देखता हूँ, मैं what I'll be saying to the next fellow is ये शेंडी लगा रहा है. So you have a good function and all that, but
Yes,
always good. You would have taken out the X-ray after, you would have taken out the frame after seeing the X-ray, na?
Yes, sir. Yes, sir.
Correct. So
After this X-ray, I have taken out the X-ray.
okay.
The dynamization film, something.
Yes, sir. Pardon, sir.
You might have dynamized this frame, na?
No, sir. I haven't dynamized the frame.
So how do you know that it is healed on this X-ray?
I have done the stress test.
Correct. So that is dynamization. What he's saying
Okay,
is,
sir. Yes, sir.
dynamization matlab you remove the,
Yes,
loosen the rods, chalao, then there is no other problem. Then again, loosen the rods,
Yes, sir. Yes,
pick
sir.
up the rods, and then
Sir.
you can walk.
Yes, sir. I did.
That is dynamization. So on this X-ray, how do you decide that it is united?
by doing the stress test, I have removed all the rod, and patient is pain free and walking without support.
Correct. But in terms of X-ray, see your lateral X-ray.
Yes.
The uppermost ring is seen as one single line. Correct?
Yes,
That means
sir.
your X-ray tech has focused on that particular ring. You can do the same thing for the AP X-ray so that you will see the metaphyseal fracture clearly.
Yes, sir.
You are not able to see.
Yes, sir.
So one of the first
Yes, sir.
things
Yes, sir.
to do for getting good X-rays is not accept poor X-rays. So if you get into the habit of not accepting poor X-rays, two things will happen. Automatically, your radiographers will realize कि Dr. Rajput,
Yes.
खराब X-ray लेंगे नहीं, ठीक सही करके भेजो.
Yes, sir.
Right.
I will.
So
Yeah,
what I would do in the beginning when I started off was call the technician and I would explain to him that देखो इसमें ये दिखता नहीं, तो ऐसा X-ray करो.
Yes, sir.
And then after 2 times, 3 times, they start doing these X-rays themselves.
Thank you, sir. Thank you, sir.
Right.
I will do next time.
I would probably also have more fixation on the proximal fragment, or I would use 32 mm, canceller screws to ensure that there is compression between the proximal two fragments.
Okay, sir.
So, but apart
sir.
from that, I think that this is good, and it shows that this thing I have already it shows that it works well for these fractures.
Yes, sir. Thank you, sir.
Amar does fracture work quite a bit. Amar,
Sir,
comment.
means one of my comment would be here the onus of reducing it and maintaining it is on olive wire. So using this CC screw would help a lot in reduction of intra-articular element, and eventually will convert this intra-articular fracture into a simple extra-articular fracture. So that frame would have less stress on first string if we have used 1 or 2 CC screws for reducing intra-articular element.
Yes, sir. Yes, sir.
And regarding removal at 3 months, I agree that this patient might have a good union at 3 months, but at times this patient gets collapse in some amount of varus post frame removal. So better to keep it where a little bit more.
Okay, sir. Thank you.
Any other inputs? Meena, sir?
Uda.
So
discuss it.
There is one question in the chat box. In such cases, what happens to the injured ACL? Making the posterior tibial slope near to 90 will prevent anterior translation of tibia, which will be provided by ACL.
Nothing happens to the injured ACL actually. It oftentimes heals off. Let us say worst case scenario and I am wrong. Then the ACL will be deficient and the patient will be symptomatic from it. All ACLs don't necessarily need a reconstruction.
Yeah.
ACLs which have frequent pivot shifts and complain of instability, they need to be treated. Now, if a patient is otherwise asymptomatic, then that even if the ACL is injured, it may not need anything doing. So I would not flatten the ACL. I would not flatten the slope just because the ACL was injured. I would like to keep the anatomy as is, and if required in the future, do a separate ACL reconstruction. That should not be a problem. That is how I would approach it.
Sir?
In which cases do we need to span the knee joint? If you got 2 or 3 good large fragments which you can fix with wires, then I would say you don't need to span the joint. If it's grossly comminuted, then yes, you may need additional stabilization across the knee. But as you can see over here, he has not required going across the knee. Shubhanshu asks, can olive wire be used for fracture compression? Yes and no, in the sense that while you are putting it on, you can, leave the olive side and then tighten a little from the opposite side to gain compression. But I would probably rely more on two cancellous screws with washers to get that stabilization. One could argue that just adding this stabilization with the olive should be enough. I would not say that that is wrong. My preference would be to use a cancellous screw to reconstitute the proximal articular block and then use wires to like the bridge between the epiphyseal block and the diaphysis. There is someone called N-048-22. I don't know what your name is.
Ashutosh. Ashutosh from Patna, sir.
Okay. वो नाम उसका N-04822 है. So he had asked earlier what is tensioning of the periosteum. So Ashutosh, if you what will happen if you pull those two tibias, the two fragments of the tibia, that is, this is related to Ritesh's case. If you pull the two fragments of the tibia apart, what will happen to the periosteum? It will become tensioned, right? So when he puts a fragment of the fibula, which is of a slightly longer length inside, the periosteum definitely gets stabilized, if not tensioned. So the important word is, I think, stability more than tension.
Sir? Yeah.
Yes, who is that? Bolna.
Yeah, Dr. Manish, I'd like suggest two things, because as Dr. Amar said, you can see the lateral condyle is not much compressed. We should first reduce it well, compress it with reduction clamps, use CC screws, and then apply olivas after that. Number two, we should, for the ligamentotaxis, you can see the joint space is reduced. So temporarily, we should use a distal femoral ring if possible for at least 6 weeks. Yeah.
Okay, sir. Yes, sir. Thank you, sir.
So first reduce, then apply CC screws, then apply olivas.
Okay, sir.
And if you don't have the fracture of the head of the fibular head gives you very good buttress to prevent the displacement of the lateral condyle.
Right, sir. But here
Yes,
we can see there's little displacement, sir. So some more compression was expected, sir.
Yes, sir.
Sir, I have a question regarding Ritesh's case. What is the protocol of lengthening in children younger than 5 years? Can we do like more than 5 centimeter lengthening?
Ritesh, answer.
Yes, sir. So actually, there is a limit of like 5 to 6 centimeter, what has been prescribed in literature, because that if you lengthen more, then it has been suggested that it can exert extra pressure on the proximal and distal physis. So if the physis were normal previously, then because of extra lengthening, this physis may get compromised and further growth at this physis may be compromised. So that is the issue. Otherwise, like in this case, the physis was already compromised and we are planning to lengthen it further. So if there are no neurovascular symptoms and if the patient is tolerating the lengthening well, then in this case, I don't think there is any contraindication to lengthen a little more.
So there are two parts to it. No, one is the congenital lengthening, and here you are not actually lengthening; you are just restoring the length.
Yes.
So the soft tissues have already been conditioned or programmed to be of a particular length. So if you are restoring length in a case where it has not been what do you call
not grown enough.
No. Restoring length where the bone loss has been there.
Yes, sir.
There, I don't think that lengthening it out to length should be a problem.
Okay, sir.
So Manish, you can stop sharing.
Yes.
Last couple of questions. What was the rehab protocol? I think this is meant for the last case. What was the rehab and when weight bearing was started, as fixation was inadequate? अभी last case का opinion देना ना.
Yes.
Manish, Dr. Manish.
Yes, sir. The weight bearing started as early as possible, as tolerated by the patients, with the help of some walker.
Okay.
Last case by Pranav.
Yes, sir. We have
Yes,
Pranav.
sir. I'll share my screen, sir. Is my screen visible, sir?
Yes.
Please go full screen.
Good evening, everyone. So after some wonderful case discussions, I am presenting a case on proximal tibia fracture. So this was a case of 28 years male patient who had a history of fall from two-wheeler 2 days back. On examination, he had swelling and tenderness over the proximal leg, and he had a significant bruising as well as blisters. So this was the condition of the skin when he came to the hospital. So on looking at this situation, so this was the X-ray. So in this X-ray, we found that there was a proximal tibia fracture, and as per the classification, this was a type 6 fracture. So we thought of options. So first option was to wait and let the swelling subside, then go for a bicondylar plating. Another option was to go for an external fixate application, which will be a temporary thing, and then secondarily go for plating. And third option was to go for ILIZAROV ring fixator with CC screws. So we thought of the last option. So this was the planning which we did. So we planned a 3-ring construct for this. We made a pre-constructed frame using 3 rings, measuring the lengths and taking all the implant in hand. So this was the first step, the closed reduction of intra-articular fracture used by of the tibial plateau using that big clamp, which is usually available. So this is usually helpful in holding the fragments in place. Then we held it with guide wires and we fixed with 2 CC screws with washer from lateral to medial side.
SMS पे आया क्या?
हाँ, SMS में आया होगा, actually support 6 digits का होगा.
Please go ahead, sir.
Yes. So then regarding application of the frame, we started with the first ring from lateral to one olive wire from lateral to medial, followed by the third ring, again lateral to medial. Then we fixed the first ring again with the procative wire and the third ring, and finally the second ring. So this was the post-op X-ray. So immediately post-op, we asked the patient to start his toe movements and his ankle range of movements as well. Day 1 physiotherapy involved active toe movements, ankle ROM exercises, knee range of movements, including static and dynamic quadriceps, as the patient tolerated. And we also asked the patient to start full weight bearing as per his pain tolerance. So this was his 2 weeks X-ray. This was his X-ray at 1 month. So this is a video of his walking at his 1 month follow-up. So this is the 3 months follow-up X-ray. We could see that the fracture has started uniting. There is a bit of callus visible in the proximal tibia. This was at almost 4.5 months. Patient was comfortable walking with the ring fixator on, and he was also able to do his knee range of movement. So at 5 months, we plan to remove the ILIZAROV ring fixator after dynamization. This is the final picture at the end of 5 months after removal of the frame. So we continued the CC screws. This is his walking video at 5 months follow-up. So my take-home message is we can consider ILIZAROV as the primary option in the poor skin condition. Preoperative planning is very necessary and helpful. The advantage of primary ILIZAROV ring fixator is early weight bearing and the range of movements, preservation of vascularity, and it is a non-invasive procedure. It has some disadvantages like pin track care has to be taken care of, and patient compliance is also very important. So thank you so much for patient listening. So I have only one case to present, sir.
Dr. Pranav,
Yes, sir.
it's a nice case. The screws
Sir.
which you used are they 6mm or 4mm ones?
6.5, sir.
Okay,
6.5.
but they look a bit thin.
No, these
Okay,
are 6.5.
they are holding well.
Yes.
So, did you face any issue with the pin tracks? Were there any
No,
cross
sir. No
infections?
issues in this particular patient because the patient was compliant and he took care of his pin tracks by self. So he was able to do the pin track dressings on his own. He learned it.
Okay.
So we can see a little early arthrosis. What is the range of motion after removal of the ring?
So range of motion was more than almost 100 degrees, sir.
That is good enough because joint specificity reduced.
No, that is not early arthrosis. That is just dystrophic changes in the tibia. You don't see changes of arthrosis this early.
Right. Right.
Eventually, with weight bearing, this will improve a lot. Bone density and all.
Right. Sir.
Somehow the PPTA seems to be towards minus side. I mean, from 80 to 70. Some collapse in the sagittal planes appear to be there. I don't know whether.
Do you have a X-ray with the patient doing full extension or even a clinical picture?
Because from this, the first 10 degree of FFD is there, which is also visible in the sagittal plane. This collapse somewhere at the fracture so that the PPTA seems to be towards 70 degree.
No, it's not only collapse at the fracture. It can just go back to your first X-ray. Pranav.
Yes, sir.
Go back to your first X-ray.
Yes, sir.
Yeah. Okay. So now
there's some angulation.
We have to. Schatzker is kind of a very old classification. and we have to look more at the 3-column concept we talk about. Now, if you think about that, number one, I would say even if you're doing an ILIZAROV, you should do a CT scan to know what is fractured, what is depressed, what needs to be picked up. All right. So here I can argue that probably there is more posterior collapse. That is, this leg has buckled in flexion as well as valgus. Okay, that's number one. Then go to your post-fixation X-ray. Lateral. Okay, so you don't have a lateral. So when you are assessing the reduction, you have to assess the reduction in AP as well as lateral.
Yes.
That can only be done when you have a good lateral X-ray where both the condyles are superimposed, and you shoot, like I explained in the other earlier case, both the ring should be seen as one line.
Yes.
Then you can say for sure that I have got fixation for meaning not fixation. I've got reduction in the lateral also.
Okay.
Now, if you see your wires over here, what is the spread of your wires?
This one, sir?
On the lateral. Keep going. Keep sharing your screen. We lost your screen just now.
Sir, I think he has exited by mistake.
Means not exited. You might have some connectivity issue.
Yeah, by mistake.
Okay. When he comes back, we'll after the next case we will take. So as Dr. Bhola pointed out, there is possibly some flexion between the proximal and that is the proximal segment and the diaphysis, and the only way to know that is by proper imaging. So that the X-ray has to be done in full extension, so that you can see that the anterior cortex of the femur and the anterior cortex of the tibia are in one straight line. And if at all that is there, it's not a difficult job to correct that. You just have to put in, you have to get the proximal ring at the appropriate angle to the distal block and use coupled washers. The other thing I wanted to point it out, which I will point out when he comes on again, is that I think he has only 2 wires in the proximal segment.
Yeah.
And the spread of those 2 wires is not very much. It may be around 15 degrees.
Almost 30
now,
degrees.
In that, when the spread is that low, you can have the proximal fragment rotating around those 2 wires. So even if your reduction is good initially, it is possible that you may get tilting later on if that fragment moves around those wires. So when we do this ILIZAROV workshop, there Pranav is connected. Yeah, Pranav, you can just reshare that file again, your screen again.
So please unmute yourself.
Yes, sir. I'm sharing my screens.
Yeah. Surprising, San Francisco में हो और साला इंटरनेट खराब है तुम्हारा.
So सिर्फ बैकग्राउंड ही सैन फ्रांसिस्को है सर, बाकी तो सब इंदौर ही है.
ठीक है, हाँ. Okay, so now if you see the lateral, your wires ka spread is not much. What happens when those 2 wires come closer to each other? It becomes effectively a single wire. Which wire will resist flexion extension of the proximal fragment?
Okay.
An antero-posterior wire. You can't put an antero-posterior wire. So therefore, if you have, let me see if I can do some annotation over here. I don't know whether I'll be allowed to do it.
Akanksha can.
Yes, sir, you can do it, sir.
No, it says you can't open a whiteboard during a screen share. There must be an annotation. Let me see.
Sir, I've added a whiteboard if you would like to.
Okay. So if you look at the proximal tibia like this.
Yes, sir.
If you put a wire like that, now your proximal segment can rotate around this wire. So having two wires like this is almost as good as having one wire. Versus if you get your wire crossing in this direction, so much of crossing, not so much posterior, of course. If you have it like this, then you've got one fixation here, one fixation here, one fixation here, and another fixation over here. So you get a very broad fixation on the proximal tibia, and then it is unlikely to flex or extend. So whenever you are putting in wires, in the workshop we say, you should try to get most bang for the buck. How do you get most? If with two wires, if you put the maximum crossing angle, then you will be able to get a better hold. So that's also something that you should remember.
Okay, sir.
Okay, and let's go back, Akansha, to his screen again. You can shut
Yes,
this.
sir. Just a second.
Yes.
Sir, you
share
can share the screen, sir.
Can I share now?
Yes, please, sir. Go ahead.
Resume. Just make it into presentation.
Yes.
Full screen.
I have done, sir.
No, अभी आया नहीं इधर, full screen नहीं आया. ठीक है, अगला slide बताओ. Go one into the X-ray slides.
This is 2 weeks, sir.
नहीं, तुम्हारा आगे नहीं जा रहा है वो.
तुम्हारे यहाँ से आगे जा रहा है, यहाँ पे नहीं दिख रहा है.
हाँ.
अच्छा.
So there's a little lag actually, sir, in the signal. That is why it's taking.
Okay. All right. Next.
So this is 2 weeks.
Yes.
This is 1 month.
Yes.
This is 3 months.
Yes.
This is 4.5 months.
Correct.
And this is 5 months.
Correct. So now, if you see all of your earlier X-rays,
yes, sir.
The same thing which I told to the earlier speaker.
Yes.
I have to insist on proper X-rays.
Proper X-ray, yes, sir.
Unless you insist on proper X-rays, they won't do proper X-rays. And unless you can see proper X-rays, you will miss these subtle issues. So now the thing to do will be to get that X-ray and see. And it is possible that there may be what seems to be a flexion deformity, because even on your clinical picture, where you had him walking on the left side and then showing range of motion on the right side, his knee was not in full extension.
Yes. So this is his video, sir.
Okay. So, and when they do full extension, you have to focus on two things. Here, what is happening is he's doing SLR as well as extension.
Yeah.
Yes.
When you want them to do range of motion, they have to stabilize the thigh against the bed and focus only on extension. Now, these are things which you have to either you teach the patient or you teach your therapist. Right? Khali पैर ऊपर नीचे हिलाने से it is not meaning they have to go on full extension.
Okay.
When you see them in the OPD, if there is no full extension, there are only two possibilities. One is that it has been fixed in flexion, or two, the patient is not exercising well. Right?
Yes, sir.
So thank you, Dr. Bhola, for pointing out that
Thank you,
important point.
Thank you, sir. Just one more. These kind of injuries, once the injury is too much, the lateral end of the femur sometimes invaginate into the fracture,
Right.
into the tibia. And I think these are the cases in which femoral ring for at least 4 to 6 weeks is very much advisable. Otherwise, again, it tries to shatter, something of that sort. That is very unstable kind of a situation in which there is invagination of the lateral condyle of the femur intra-articularly into the
So that's what yeah, I mean, that is same thing that I was saying, that you should almost always, I think today you should do a CT scan to see if there is a compressed fragment in the lateral condyle. And if there is, then certainly you should have wires which are rafting under the articular surface, or two screws which are rafting under, to prevent that subsidence. And if there has been a significant depression which has to be elevated, that point is well taken, that there may be a role for extending across the femur, just to prevent that femur from pushing into that elevated fragment again.
Sir, many people recommend the distal femur ring routinely. The advantage is to allow early weight bearing. Like that will avoid
What
collapse.
is the advantage of early weight bearing?
Like it won't allow the collapse of the proximal tibia, and patient can.
Correct. So that is only in a case which Dr. Bola pointed out, that where the femur has impacted into the lateral condyle. But otherwise, if it is just a split, two condyles split, and you get good fixation with the screws, then it's not going to collapse. If there is an intra-articular depression which has been caused by the femur, then you may consider that. But even there, if you put good raft screws, then that intra-articular depression is not going to compress further.
Right, sir.
So if we are applying a femoral ring as well, so when should we remove it then?
About 4 to 6 weeks.
Okay. So will it not affect the knee range of movement, sir?
It will. That's why you don't put it in every case. But then you have to balance between maintaining your reduction and range of motion. And if you put the femoral ring properly, in the sense that you put in a posterolateral and a posterior shan spin, which is going as far as possible through the interval between the flexors and the extensors, then the likelihood of impeding knee motion is minimal.
Okay.
Amar, any additional things to add?
No, I agree. I agree, sir.
My just one question, sir. Can we add a shan spin in the first ring, R1, in case we are not getting a good span of the wires?
You can, but especially when the fragment is smaller, I would tend to rely more on the wires, number one. Number two, when I'm putting in the wires, I'm always looking for the feel. So I put it in through the proximal cortex, definitely I'll get a feel. But when I'm coming out, do I get the feel of the opposite cortex? So then I know that my wire is anchoring well in both the near and the far cortex. Shan screw, yes, you can put, but I would tend to use the shan screw more when there is a a large single fragment where I can direct the screw well. Otherwise, I think the wires in this situation do a good job. But of course, no objection to using a shan screw.
Could it have been corrected by using the hinges and distractor, like in this case?
Why you need a hinge and distractor? You just angulate the proximal ring to the distal block.
Okay.
Because this is a fracture, no? This is going to straighten out right away. This doesn't need gradual distraction when you put it on. If you find it out 3 weeks later, yes, you can put on hinges.
Okay, sir.
But what I'm saying is, on table only, before you finish, you should know that my AP reduction is good, my lateral reduction is good. And for that, you need good imaging. Because the best way to get this condyle superimposed is under CM.
And have more number of wires, 3, 4, 5 even. So that you have complete purchase on the proximal fragment.
Yeah.
We said there should be more drop wires. And sir, what is the general consensus in applying a distal femoral ring for 6 weeks? Should we do or not, sir?
We just discussed that. I wouldn't do it unless there is a intra-articular depression.
Right, sir.
So as a general rule, putting on a femoral frame, I don't think is required.
Right.
If you have severe combination, if you have depression, have the issue of this instability, then we can go ahead with the proximal ring the femur.
Right.
Okay, next.
Sir, Prashant is not there to present his case.
So the next, some guys had 2 cases, no?
So
Yeah.
it's around 1.5 hours. If you wish, we can take one case or we can conclude.
In short, we can do both, I think.
Sir, if time permits, then I will present a case which is going to just point out all the things which has been discussed just now.
Okay, go on.
Okay, then I'll share my screen. And is it visible, sir?
Yes.
Yeah.
Yes.
So this is a 38-year-old male patient. He is a Halwai by occupation, and he actually fell from a tree and injured his right lower limb. And at his village, he was treated with some sort of a bandage, which had indigenous medicines, and a bone setter had treated him. So he presented to us after 5 months of the injury. And at this time, he had a deformity and he was unable to walk at all. So this is the X-ray with which he presented to us. So when we clinically examined, so there is a varus deformity, which is just distal to the knee joint. There is an abnormal mobility. There was minimal pain when we stressed that area during examination. So what we can make out is that there is a fracture, which is now almost looking like a pseudoarthrosis type of thing. And this fracture of the metaphyseal area is also accompanied by a fracture of the fibular neck. On the lateral view, if we see, then the area where the bone is there is quite less. So at this stage, when the patient came, we thought of doing something for him. And in this case, are there requirement of any other investigation? Probably yes, probably no. I thought I knew much with this clinical examination and X-ray only, and did not proceed with any investigation. Then what was the surgery which what be done? Now the fragment was quite small. So instead of opening up and putting in a plate, we thought that probably using ILIZAROV principle of gradual deformity correction and providing stability, we should be able to get away. So the implants which were used were a standard external fixator and then any specific steps. So primarily because we wanted the deformity to correct well, so we removed a small segment of fibula, extended the frame proximally, and initially put on a 5 millimeter of distraction for the knee joint also. So this was the case, and we applied the hinges in an oblique plane. So we had deformity in both the planes of varus as well as a procurvatum. So we placed the hinges in an oblique plane. But again, as Mangal sir pointed out, while one of our X-rays, the lateral looks good, the AP could have been better. But we proceeded with the frame across the joint. And then at 1 month, so this was the picture. So we had achieved the alignment which we were looking for, and we had actually overcorrected by about 5 degrees. At this level, we allowed the patient to weight bear. And at 3 months, we removed the femoral ring. Only the tibial ring was remaining. He was allowed to walk with the help of crutches and weight bearing as tolerated. At 4.5 months, his knee range of motion was from 10 to 50 degrees only, but it was pain-free, and he was putting about 50% of weight. And the X-rays looked a bit encouraging to us. So we dynamized, and after 15 days, we removed. So what we found was that the fracture looks united well. AP is fine, but again, there is a malalignment on the lateral view. At this stage, we usually put in a cast for some peace of mind, and we use this cast for a month. Then at 8-month follow-up, the patient had some improvement of his range of motion. However, a flexion deformity, as was there in Pranav's case, because of this slope, tibial slope, you can easily see that it is still persisting. The patient has now come on, started to walk with a stick from a pair of crutches to single stick, but he started to have some pain when he walked for more than 2 kilometers. But it was well controlled with the help of analgesics. So at 14-month follow-up, he came back and he pointed to an area where he had localized pain. And on the lateral view X-ray, we could see, and this was the area where he was tender, that there was a ring sequestrum. So at this point, we, under local anesthesia and image guidance, we curated this small sequestrated area, the ring area, and his pain had improved at this time. He continued walking well, and then he came after 2 years of follow-up. So this was the picture with which he came. Now the pain had decreased. It was just 10 to 30 degrees. And X-ray wise, he had developed secondary OA of the knee, primarily involving the lateral side. At this moment, I took help of my arthroplasty colleague. And last month only this patient was operated. And when he opened up, he came back and told me the different findings. So the patella was fine. The femoral side was fine, but tibial side had cartilage loss on both sides. He had defect in the tibia. There were 2 defects, one a relatively smaller one on the lateral side and a relatively larger one on the posterior side. So he used the femoral cuts and filled up that those defects, and he performed the arthroplasty. But after this event, I went back to the X-rays again to see whether my judgment of not getting an investigation was right or wrong. And these were the 2 lines which I had seen earlier, but neglected that, thinking that these, at the end of 5 months, they would have already settled and healed up. But probably these are those areas where the fracture had a significant depression. This depression was lateral as well as posterior. And when the patient actually started to put the full weight, that area continued to get further depressed. Even though the fracture in the metaphyseal area healed, probably the fracture in the articular surface was not strong enough and to take the load of that patient. So what went wrong and what did we miss? So I will request senior faculty to comment now, please.
To go back to your first post-op X-ray.
So this is the immediate post-op X-ray.
Okay. And then the next one.
So this was at 1 month. So when we had corrected the deformity.
Correct. So what do you see now? No. Stay there. What do you see now in the knee?
In the knee, it appears as if there is some amount of valgus going on. That the same thing with Dr.
On the lateral X-ray.
Lateral X-ray is not very clear.
You can see the distal femur and the distal tibia.
Yes, sir.
What's the relationship between them?
So the space is not very much visible as of now.
No, what's the angle between them? It's flexed.
Yes, sir.
So there is, if you go back to your pre-op X-ray, you'll notice the PPTI is abnormal.
Yes, sir. So actually we put in the frame which aimed to correct the oblique plane, but still we were unable to correct it properly.
So
Completely.
unless you do proper imaging, you cannot decide whether or not you have achieved what you set out to achieve.
Yes.
In this X-ray, you have not achieved what you set out to achieve.
Okay.
Okay, next. Same thing here. Next. So more than the depression of that particular fragment, one thing is, if you will find that there is a shear happening in the this thing. plaster is also in flexion.
Yes, sir. Correct.
There is no reason to give a plaster in flexion unless you could not get extension.
Yes, sir.
Okay, then go ahead. So here now you will notice that there is a significant flexion, and when you walk on a flexed knee, there is a shear force that is coming up. So, and this is why when we talk of HTO, we say you have to look at all the orientations, frontal as well as the sagittal. Just go back. Go forward again. Go forward. Right. So his cause of pain is equally likely to have been the continuing osteoarthritis. Forward again.
Sir, at this stage, actually, when we did the curettage, he was fine.
Okay.
So then he came after, this was 14 months. Then he was not he didn't come for this rest of the period. Almost 10 months. After 10 months, he came. Now he came with pain with every step.
Correct. Now, when you are imaging an AP X-ray in a patient with a flexion deformity, you can't really rely what you're seeing on the AP, because you're not seeing an AP of the knee, which is what you're used to seeing.
Yes, it is a flexed AP.
Yeah. So now if you stop sharing, I'll just show you some 3 slides and we can end this.
Sure, I'll just close it down.
Prateek, why did we choose the ILIZAROV in this case? Like it could have been corrected simply by a plate, like.
So that was the issue when we looked at the initial images. I thought that the space for putting in screws was quite less. The possibility of getting hold onto that fragment was limited. So if we look at the lateral view, the amount of bone on the towards the articular side was less. So I thought instead of trying to put in a plate and getting a non-union, it is better to achieve an union. And in my mind, I was thinking that the articular segment had already healed by 5 months. It was a significant period of time after which he had come.
I think ILIZAROV is a good way of getting this. Now here is a patient who, despite all kinds of tries with traction and all, would not reduce, and then someone sent him to me. So his skin is bad. Okay, you can see the distractor pins bending. We put on a distractor to try and reduce it, it wouldn't. Then with a combination of joysticking and putting a lever into that, we were able to get this reduced. And this is what I mean by rafting screws which are close. Now we've got a good reduction of that articular fragment, and we only need to get the proximal aligned to the distal and neutralized. So your screws frequently should go as close to the articular surface as possible. Plus, there should be enough distance between them. This is what I mean by seeing what it looks like in the lateral, right? And I got full extension over there. And then we just put it with relatively simple frame, 3 wires in the proximal. Here we've got that spread which I told you about. And the soft tissues, once it is stabilized, they improve. So all the X-rays that we do also will have this kind of appearance, where I can make out whether or not there is a flexion. Now here's another one with an intra-articular portion, multiple fragments. Here you can see that this lateral condyle is kind of depressed. This is what Bhola was pointing out. So here we can reduce this through the fracture side, and then again get these rafting screws. Again, you want to see that you can see both the condyles and your articular surface is sort of well reduced on the lateral as well. And then use the ILIZAROV. So here we've got those screws close to the articular surface, and then we've got wires, and we've got what do you call drop wires, right? Now, if that reduction is not perfect, which you can see here, it is not. This is a very oblique fracture surface. Then you can use a 6-axis to get this into perfect reduction. And then it goes on to heal, despite the fact that he had a wound over there, goes on to heal without any major trouble, right? So again, X-ray in full extension. That is the so you can always use the 6-axis for fine tuning, but the articular surface you can only reduce it on table. You can't use a 6-axis for reducing the articular surface. The proximal to the distal fragment you can reduce using 6-axis, hinges, coupled washers, etc., etc. Now, just because we are using the ILIZAROV, we should not take the excuse that, okay, we did this minimally invasive, so a step or poor reduction is acceptable. The articular reduction, if required, can be done with a mini open, but the stabilization is done. So you have to separate the reduction and the stabilization. Right? So I think we've reached our time. Any final comments? Bola?
Sir, just one point. In the last case which was presented, and that has many things to be learned. One another thing is, if we are dealing with such kind of deformities, non-unions, CT scan, especially the 3D CT scan, would have shown so much light on that,
Yes.
that we would have been warned what he is going to deal with.
Correct.
3D CT scan.
I would say that a 3D CT is mandatory today. Would you not do it if you are doing internal fixation? Yes. So why ILIZAROV should be any different?
Yes, sir.
You're right. Judging the personality of the fracture by a CT scan and the intricacies of the fracture, I think is appropriate.
You are correct. Actually, I probably erred in my thought process because it was 5 months when the patient came. So I thought that the proximal part is already glued up.
Correct.
So I might not be able to address anything without that.
Some things now I would suggest to everyone is there are certain things which should be protocolized and they should not be put based on case to case. For example, part of the proximal tibial fracture, distal tibial fracture, I think a CT scan is kind of part and parcel of the protocol.
In that case, might be there was a crater already that led on to osteoarthritis of the knee. If CT scan would have shown that, yes, there is a crater, that would have warned us.
Yes, sir. That crater was pointed out by my arthroplasty colleague. And then I realized that probably CT scan would have been done. It could have been better, much better.
Thanks.
Okay. Jayant, any thoughts?
No, sir. Everything has been covered quite nicely. I think it was a good learning session today. Amar, you want to add something?
No, sir.
So I think intra-articular reduction is important. The ILIZAROV is used only to if you use olive wires to keep that reduction. ILIZAROV is not magic that wire dal diya or reduce ho gaya. Reduce karke, then you have to hold that reduction. Most of us, I think, would say that preferably by cancellous screws if possible, but you can use olive wires also. That is number one. Number two, adequate number and adequate spread of wires in that proximal segment. I showed you 2 cases now, one of which we had the depression also, which I have reduced. But since I had good raft screws and wires in that, I didn't need to bridge the femur. And to my mind, hardly ever I need to bridge it. But if someone says, no, I'm not sure, and I think I would prefer to, yes, I don't have an objection to that. And finally is like adequate stabilization, ambulation, rehab, the range of motion, muscle strengthening, etc. Keep a check whether or not there is a flexion deformity, because flexion deformity is quite disabling in terms of walking. And finally, before taking it out, have appropriate X-rays and do the stress test, the minimization. So I think good cases presented by everyone. Thank you.
Yes.
And
Thank you, sir.
we can sign off.
Thank you. Thank you very much, sir.
Thank you, sir.
Bye-bye.
Good night.
Thank you, sir. Thank you.
Thank you, sir. Good night, sir.
Thank you, sir. Stopping the live streaming now.
Good night.
Yeah,
Good-
before
Thank you, sir.
Amar has to say something.
What?
Amar,
Who wants to say?
No, sir. आप बोलिए ना सर.
नहीं आप बोल दो.
ये जो सर टुडे वी हैव लॉस्ट दिस डॉक्टर रानावत सर.
हाँ.
तो वो एक जस्ट बोलना रहेगा ये लाइव सेशन में.
हाँ.
हाँ बाकी तो
ठीक है अभी वो.
हाँ चलो.
You can just put a message on the group that we condole
Yes, sir.
the passing of illustrious.
Lastly, there are a lot of new members I'm seeing today. Request them to join the ASAMI group and register for ASAMICon as soon as possible.
Yes, sir.
All right. Bye-bye.
Bye-bye.
Thank you.
Okay, bye.
Thank you very much, sir.
Thank you, sir. Good night. Stopping the live.